Hello, my name is Rosemary Morgan, and I'm on faculty at the Johns Hopkins Bloomberg School of Public Health, where I study issues related to gender and health, as well as gender and health systems. I am currently part of the Gender and COVID-19 Working Group, which has recently published a commentary in The Lancet about the gendered effects of COVID-19. I want to talk to you today about the gendered effects of the epidemic, which are both direct and indirect. In terms of direct effects, we know that there are biological differences between men and women that affect their immune responses. In our work related to influenza, for example, we see women having a better response to the influenza vaccine. However, we don't really have a lot of sex-desegregated data related to COVID-19, both in regards to infection rates and mortality rates. Early data suggests that men are more vulnerable. In China, Italy, and Spain, for example, where we're seeing some sex-desegregated data, the mortality rate is higher among men. The reasons for this are likely to be both biological and behavioral, related to both sex and gender. However, at this point, it is still too early to tell exactly what the causes are. When you look at sex-desegregated differences to non-communicable diseases, men engage in higher behavioral risk factors, such as smoking and drinking. Such behavioral factors can lead to comorbidities such as diabetes or high blood pressure, which can increase risk of complications following infection. However, the smoking rates among men and women in China is different than in Italy and Spain, where we are seeing sex-desegregated data. While a lot more men are smokers in China, 47.6% compared to 1.8% of women, there is less difference between men and women in Italy and Spain, although we still do see a gap. We saw a similar pattern during the SARS and MERS outbreak. While more women than men were infected by SARS, in Hong Kong, for example, the death rate was higher among men. We also see that women are often more proactive in seeking healthcare compared to men. There is evidence to suggest that patients whose diagnoses were delayed were at greater risk of dying. In addition, evidence shows that men are less likely to wash their hands or use soap compared to women, which is an important preventative public health practice. While it is important to explore the direct gendered effects of the epidemic, I also wanted to highlight some of the secondary gendered effects, where in many cases, women are more affected. For example, COVID-19 puts women at disproportionate risk, not just of exposure to the virus, but also economically and socially. Women are on the front lines as healthcare workers, primary caregivers, and migrant workers. Women, for example, make up 70% of the global health and social workforce. We're also seeing increases of rates of domestic violence, which predominantly affects women. There is also risk of resources for reproductive and sexual health being diverted to the emergency response, which contributes to a rise in maternal mortality, which we saw during the Ebola epidemic in Sierra Leone. It is estimated, for example, that there were at least 3,600 additional maternal, neonatal, and stillbirth deaths as a result of a diversion of resources towards Ebola. Ebola also saw an increase in teenage pregnancies, which resulted in many girls not returning to school. And lastly, women are not equally represented in decision-making roles responding to the COVID-19 pandemic. The White House coronavirus task force is over 90% men, and the team the United Kingdom's Prime Minister assembled to lead their response is all men. When women have less decision-making power than men, either in households or in the government, we know that women's needs during an epidemic are less likely to be met. And we have evidence from the Ebola and other epidemics which we can learn from. Epidemics, including COVID-19, are not gender neutral. In the face of all this information, we call on governments and organizations to consider both the direct and indirect gender impacts of epidemics, collect both sex-desegregated data and gender data, and ensure gender-sensitive strategies in their COVID-19 preparedness and responses. Thank you.